Good evening to everyone. We'll discuss about transposition of great arteries today. I was told that in another week's time there will be a surgical perspective of transposition of great arteries also. In this few minutes, I would like to stress on various aspects regarding transpositions anatomy, transpositions hemodynamics. Transposition is the commonest cyanotic heart disease in a neonate. The commonest heart disease in cyanotic heart disease in the entire population will be tetralogy of Fallot. But when it comes to presentation at neonate, the commonest heart disease is transposition. It accounts for about 8% of all the congenital heart disease. It's associated with AV concordance and VA discordance. Aorta arises from the right ventricle, CA arises from the left ventricle. More number of males are affected. There is an association with maternal diabetes. The classical hallmark of the disease is pulmonary mitral fibrous continuity. It's important to note that transposition is a peculiar disease where there are not many associated anomalies. That means, you have a patient with ASD, you will have something like Holt-Oram syndrome. You have a patient with VSD, there will be somebody who will have anorectal malformation, vertebral anomaly, ear anomaly. Whereas transposition, most of the babies will not have any other associated abnormality, and less than 10% have other associated anomalies. Embryologically, it is caused by the common arterial trunk failing to spiral septum doesn't form properly. It is also said to be due to failure of growth of the subpulmonic conus and abnormal growth of the subaortic conus. If you look at the physiology, the systemic veins, venous blood goes back into the aorta and pulmonary venous blood goes back into the pulmonary artery. So this causes a parallel circulation. So if the patient has to get some oxygenation, you need some intercirculatory mixing. Intracardiac, it can be at ASD and VSD levels. Extracardiac, it can be at PDA and bronchopulmonary collaterals. If you look at this left ventricular angiogram of a patient who is having transposition, the left ventricle fills the pulmonary artery, pulmonary veins fill the left atrium, again the left ventricle fills and the pulmonary artery fills. You don't find a filling of the right atrium and the right ventricle at all. This is what is called parallel circulation. The blood keeps on going in the left side of circulation, the oxygenated blood. The deoxygenated blood keeps on going in the right side. They don't mix at all. This peculiar parallel circulation is very peculiar for transposition. So always the PA saturation will be higher than the aortic saturation. This is the hallmark. Timing of the presentation, it's imperative that the child has to present immediately after birth. There is no way in which a transposition can have a delayed presentation. It's a parallel circulation. So the hypoxic blood has to go into the aorta. There is no way a transposition can have a normal PO2. Sometimes you will find saturations are not very low. You may have a saturation of 90%, 92%, 93%, and so cyanosis may be missed. Why is this so? We need to understand it very clearly. We need to understand what is a fetal hemoglobin. Fetal hemoglobin has got a high affinity for oxygen, and it shifts the oxygen dissociation curve to the left. So, for a given PO2, see here, this is 40. For a given PO2 of 40, a normal hemoglobin will have a saturation of around 75, but a fetal hemoglobin may have a saturation even 92, 93. So, in fetal hemoglobin, for a given PO2, the saturation will be higher. Now let me tell a corollary. For a given saturation, the PO2 will always be low. So, to assess the neonatal hypoxia, the neonatologists traditionally had been relying more on PO2s rather than saturations. If you see what is the hyperoxia test, hyperoxia, hyperventilation test, definitions and all, nobody talks about saturation. They all talk about PO2. PO2 on hyperoxia, hyperventilation test of less than 150 is considered to be pathognomonic of something in the heart. This is what is the definition. So the reason why we need to understand it is you will always have a PO2 less than 40, but you may sometimes have a saturation which is 90 or 91 or 92. So we need to understand that transposition will present with instantaneous hypoxia immediately after birth, and the hypoxia will manifest primarily on PO2s. So in TGA, PO2s will always be less than 50 millimeters of mercury or 50 torr. What is the fetal circulation in transposition? Brain and the heart receive blood with less amount of oxygen because the superior vena cava blood comes to the right atrium, goes through the tricuspid and the right ventricle and goes into the ascending aorta. That ascending aorta perfuses the brain and heart and receives, so that has less oxygen and less glucose. What is the significance? Head is often small, brain is often small. There will always be some minor IQ defects. If you do some MRI scans on these patients, there will be some sort of subtle neurological differences. Pancreas receives hyperglycemic hyperoxic blood. So the pancreas hypertrophies, the islets of Langerhans hypertrophies. More insulin is circulating in the blood. So you have a large baby with a small head. And there is postnatal hypoglycemia because of excessive amount of insulin. In normal heart, during the transitional circulation, there is an increase in the left atrial pressure because blood starts to go from the right ventricle into the pulmonary artery. Instead of going into the ductus, it starts to go into the pulmonary arteries. So more amount of pulmonary veins return back the blood to the LA. LA pressure increases. And the LA pressure increase closes the PFO. But what happens in transposition? RA pressure is high. Why? RA is connected to right ventricle. Right ventricle is connected to systemic artery. So right ventricular systolic pressure is very high. So the RA pressure is high, and so the PFO remains open, and that is the reason why these children survive. They are also notorious for developing high pulmonary vascular resistance. It's important to know why they are prone for high pulmonary vascular resistance. TGAs have abundance of aortopulmonary collaterals. They may not be visible like a tetralogy pulmonary atresia, like snake-like vessels, but they are multiple, tiny, diffuse, and it goes everywhere. These aortopulmonary collaterals give the hypoxic blood to the precapillary arterioles. When aorta is pumping the blood through these aortopulmonary collaterals into the precapillary arterioles, there is a high flow and there is a high pressure. So this causes shear stress and endothelial damage of the pulmonary capillaries. The arteriolar level endothelium has got shear stress and endothelial damage. Now, a transposition who is having a ductus open in the first 2 to 3 days, the patency of the ductus with hypoxic blood that is coming from the aorta goes into this pulmonary artery, and that hypoxic blood further causes trigger of pulmonary vasospasm. So when there is a high flow related and high pressure related endothelial damage caused by the shear stress, this endothelial damage results in platelet activation and platelet adhesion, may form microthrombi, and that will release lot of platelet mediators, which causes further and further pulmonary arteriolar changes. And to compound to it, polycythemia that happens due to hypoxia also worsens the PVR by increasing the blood viscosity. So due to this variety of reasons, transpositions are notorious to develop pulmonary vascular disease. If you have a patient with a transposition with ventricular septal defect, around 20% of them will have very high pulmonary vascular resistance even before 2 months of age. So that's the reason why transposition with VSD, we should try to operate within preferably a month or so. If you delay beyond 2 months, 20% of them will already have pulmonary vascular disease, and if you wait more than 1 year, 80% of them will have pulmonary vascular disease. What about transposition with intact ventricular septum? Even there, vascular disease is more common. 1% may develop pulmonary vascular disease even before 2 months. Around 17% between 2 months to 12 months. And about a third after 12 months. That means after 1 year, if you are having a transposition with intact ventricular septum, 1/3 of them will have high pulmonary vascular resistance. when does a transposition present? I told transposition presents immediately after birth. There is no way in which the child can have normal PO2 levels. Immediately after birth, the PO2 will be 40 or less than 40. So what decides how bad a child is going to be? It is the adequacy of atrial communication, presence or absence of VSD or PDA, presence of arch obstruction. If you are having a adequate intratrial communication, these children will have hypoxia but will not become critically hypoxic, and so they will continue to live. If they have presence of VSD or PDA, they will have abundance of pulmonary blood flow, so cyanosis will be less, but they will go into heart failure. If they have an arch obstruction, they will have severe congestive heart failure, and so they will present very, very early in the neonatal period. The occurrence of cyanosis will be very early in neonatal in TGA with intact ventricular septum, and with people who are having large VSD or large PDA, the presentation may be delayed. It's nowadays very common to have almost all the transpositions detected by fetal echocardiography, because one of the classical hallmarks of transposition is this parallel to great arteries, and this never occurs in a normal heart. And so if there is a normal crossover of the aorta and pulmonary artery is absent, that's a classical hallmark of transposition. Transpositions are easy to pick up. So most of the transpositions get diagnosed now on fetal echocardiography. If you have a postnatal echocardiogram, this is RV giving of the aorta anteriorly, LV giving of the PA posteriorly, two parallel great arteries, and this parallel great arteries is the classical hallmark of transposition. In subsequent view, the posterior pulmonary artery, anterior aorta, they course like two parallel tracks. So parallel nature of the two great arteries is the classical hallmark. Classification of transposition is into simple TGA and complex TGA. Simple TGA refers to TGA with intact ventricular septum. You may or may not have a PDA. If you have a VSD, then there should be a very, very small VSD. There should not be anything else. Complex TGA is TGAs with either large ventricular septal defect, or LVOT obstruction, RVOT obstruction, or very large PDA associated with some pulmonary vascular disease. Echo assessment of transposition will be looking primarily at atrial septum, because atrial septum can have restrictive PFO large ASD. Ventricular septum, because we may have intact ventricular septum or you may have ventricular septal defect, and if so, where is that defect? You will see. Great artery relationship, presence or absence of LVOT or RVOT obstruction and coronary arteries. Intratrial septum. It is the adequacy of intratrial communication that decides the survival in a transposition with intact ventricular septum. Almost all children will have a PFO. I told you the PFO will always be present, because right atrial pressure is higher than the left atrial pressure in a transposition, unlike in normal neonates where left atrial pressure will increase more than the right atrial pressure and close the PFO. Here, PFO cannot close completely, but it will be tiny. If it is very tiny, they become hypoxic. If it is reasonably adequate, they will be less hypoxic. To understand some terms, what is QP, what is QS, what is anatomical left-right, what is physiological left-right, what is anatomical right-left, what is QEP, what is QES. These are all certain terminologies that we need to understand so that hemodynamics of TGA can be understood. This is a picture copied from MADRAS. Superior inferior vena cava blood returns to the right atrium, and this is the systemic venous return. This entire systemic venous return directly passes through the RA, RV and enters the aorta, and that is what is called the characteristic hallmark of TGA. So the systemic venous blood enters the aorta. Now if the entire systemic venous blood is continuing to enter the aorta, the patient will become hypoxic within 2 to 3 hours and the child will be dead. So there needs to be some intracirculatory mixing. A small amount of the systemic venous blood will cross over from the right atrium into the left atrium, and this right atrium to left atrial crossover is called as the anatomical right to left shunt. So this anatomical right to left shunt is basically the venous blood, systemic venous blood, that is the blue blood that is able to enter into the left side and go into the lungs. So this is the effective pulmonary blood flow. The effective pulmonary blood flow is the amount of blood that is crossing over from the right side into the left side, which is the systemic venous blood that enters into the lungs. The pulmonary venous blood that is carrying the oxygenated blood, entire pulmonary venous blood will be keeping on going into the lungs. So the entire left side will be fully saturated and pink. But a tiny amount of blood will cross over from the pulmonary venous side through the ASD or VSD into the aorta, and this is the blood that is going to oxygenate this child. And so this is called as the effective systemic blood flow, or QES. So in all the patients, this QES and QEP has to be the same, because if suppose the QES is in, let us assume that there is in one cardiac cycle, the baby is ejecting some 30 ml of blood, and let us assume that 3 ml of blood is crossing over from the left atrium into the right atrium, and 4 ml of blood is crossing from the right atrium into the left atrium. So what happens? In one cardiac cycle, 1 ml is gained. The heart rate will be 140. So in 140 cycles, 140 ml will be gained. And imagine in 1 minute, some 50,000 ml will be, and in 1 day, some 1,500 liters will be gained. So there is no place in the heart to accommodate. So whatever blood is crossing over from right to left will be matched by the amount to right to left, left to right. So QEP and QES will be the same, and what is the effective pulmonary blood flow is the anatomic right left shunt, and whatever is the effective systemic blood flow is the anatomic left right shunt. So what is the blood that is waste going? The pulmonary venous blood directly goes into the pulmonary artery, so this is a wasted blood. And similarly here the systemic venous blood is going directly into the aorta, so this is a wasted blood, and that is what is called physiological right left shunt and physiological left right shunt, because pulmonary venous blood enters the lungs, and so this is the physiological left right shunt. So these terminologies you need to understand clearly. This is the atrial level admixture. You can see there is this left atrium, right atrium, there is an ASD, and there is a blood. Sometimes it is red, sometimes it is blue. So that is the bidirectional flow. Now to understand what is this bidirectional flow, in diastole, both the tricuspid valve and mitral valve are open. Both the left ventricle and right ventricle are now relaxing in diastole. LV is more compliant because LVSP is low. RV is less compliant because RVSP is high. So what happens? Blood preferentially moves from right atrium to left atrium. So in diastole, when the tricuspid and mitral valve are open, the blood moves from the right atrium to left atrium. What happens in systole? Whatever blood has crossed over from the right to the left will go through the pulmonary artery, fill the lungs, return back in the pulmonary veins, and this increased pulmonary venous return due to this high QP now is coming back into the left atrium. Now what is happening? Both the tricuspid valve and mitral valve are closed. So you are having pulmonary venous blood that is coming back from the pulmonary vein into the left atrium with a closed tricuspid and mitral valve. We all know that left atrium is less compliant than the right atrium. So what will happen? Blood will flow from left atrium to right atrium. So in diastole, blood moves from right atrium to left atrium, and systole, blood moves from left atrium to right atrium. So what are the factors that influence this mixing? Obviously, the first thing that I told, RV is less compliant, LV is more compliant because LV is thinner, RV is thicker. Now, is that the only thing? Is it so simple to understand? Respiratory cycle. When I inspire, I suck in the superior and inferior vena cava blood back into my right atrium, and so there is an increased systemic venous return. So that is also going to change the mixing transiently. So there will be some respiratory variation. What happens to heart rate? If the heart rate is very fast, the cardiac output is very high. Cardiac output is very high means venous return is very high. So venous return is very high means mixing is very high. So heart rate is higher, mixing is better. So you know, in the past, before all this septostomy and all these things happen, when you have a patient with transposition of great arteries who is having very severe hypoxia, doctors used to treat this patient by giving repeated injections of atropine just to keep the heart rate high. You have the heart rate high, you'll have better cardiac output is survival for a little more time. And second thing that they will do is, increase the intravascular volume. That means put in a cannula and keep perfusing them with fluids. You have higher volume, you have better saturation. So these are all heart rate, lower the heart rate, less the mixing, lower the intravascular volume. So if you say the child is dehydrated, the child is being kept on a warmer, the child is not being hydrated, the child is left with no fluid and is transported for 12 hours from one hospital to another hospital without any IV fluid, this child will become terribly hypoxic. What is the reason? Intravascular volume is low. Presence or absence of left ventricular or right ventricular outflow tract obstruction, because obviously this is going to affect LVOT obstruction. We can very easily say that QP will be low, RVOT obstruction, QS will be low. Relative systemic vascular resistance and pulmonary vascular resistance. In the earlier phases, the pulmonary vascular resistance will be low. However, in transposition who are getting advanced disease, like say at the end of 1 year in a transposition with PSD, PVR will go above the SVR. So that is also going to decide the mixing. Location of the defect. Let's assume that you have a perimembranous ventricular septal defect that is located in the subpulmonic location. When the RV pumps, directly the blood will go into the pulmonary artery. So it's a good right ventricle to pulmonary artery direct flow. On the same hand, if you are having a Swiss cheese, apical muscular ventricular septal defect, the amount of mixing will not be so high. Whatever blood is coming from the tricuspid valve will silently go into the aorta without getting mixed at the apical portions of the septum. So, location of the defect, straddling and overriding of the valves. If you are having a mitral valve that is straddling a large ventricular septal defect, all the pulmonary venous pink blood that is coming from the LA through the mitral valve will straddle out because of the override, enter into the right ventricle also, and these patients will have a higher aortic saturation just because the mitral valve is straddling across the ventricular septal defect, you have a better saturation. So the questions for a postgraduate student: what are the factors that influence mixing? It is a compliance of the chambers, the respiratory cycle of the patient, the heart rate, the intravascular volume, presence of outflow tract obstruction on right or left side, relative systemic and pulmonary vascular resistance, location of the defect, straddling and overriding of the valves. In between, I will tell something like text what is needed for exam, and in between we will try to understand physics. Interventricular septum in a simple transposition. In a transposition, the ventricular septum is going to tell us and indirectly what is the left ventricular pressure and whether the left ventricle is adequate for an arterial switch or not. And the ventricular septum, if it moves abnormally, it may cause dynamic LVOT obstruction. So this is how the interventricular septum will be. This is a subsified view. Interventricular septum bows into the left ventricle. The great artery relationship in a transposition, it may either be right and anterior, sometimes anteroposterior, sometimes left and anterior. Very, very, very rarely it may be normally related. So this is right and anterior, right aorta, left PA. This is directly almost anteroposterior. This is L malpost. This is left and anterior and right and posterior. And extremely rarely you can have completely normally related great artery. This is aorta. This is pulmonary artery, and this is the coronaries. So aorta and pulmonary artery are normally related. However, the vessels, the great vessels will be parallel to each other. They won't spiral around. Assessment of left ventricle in a transposition with intact ventricular septum. Why is it important? We need to understand whether the LV is prepared for an arterial switch. Before birth, LV and RV have similar pressures and similar mass, and so obviously left ventricle or right ventricle any ventricle can take systemic circulation. But after the baby is born, when the fetal pulmonary vascular resistance falls, left ventricle involutes. Once the left ventricular mass becomes very low, it cannot pump against the systemic vascular resistance because of afterload mismatch. So how to recognize this? There are various parameters: free wall thickness, mass to volume ratio, shape, interventricular septal configuration, left ventricular systolic pressure from MR jet if you are able to get an MR. Just like how you assess tricuspid regurgitation jet and assess the RV systolic pressure in a normal heart, you can assess the LV systolic pressure by the MR jet. So this is the LV free wall thickness. In diastolic free wall thickness, if it is less than 4 mm, it is of concern. This is free wall thickness is best assessed by MO, and because now you know which is diastole and which is systole. If you go and take in systole, it will be thicker. So you need to take in diastole. LV mass. Mass is calculated by tracking the endocardial border, epicardial border, seeing the length, and you analyze what is the mass. A mass of less than 35 grams per meter squared, mass index of less than 35 grams is bad. Mass to volume ratio, you look at what is the volume also. Mass to volume ratio of less than 2.5 gram per ml is bad. Shape change. The normal left ventricle is a prolate ellipsoid, but this is now a squashed banana-like appearance. So this is also bad. The shape has become altered. Interventricular septal orientation. The normal interventricular septum should be bowing here, but this is now bowing into the left ventricle. So interventricular septal orientation, how badly it bows. There's also another index that has been introduced called as the anteroposterior diameter to lateral diameter ratio. So this is septum, so this is anterior, this is posterior free wall, so this is anteroposterior, and this is lateral, this is subsified view. So in subsified view, everything here is anterior, everything here is posterior. So this is the anteroposterior diameter and this is the lateral diameter. If you are having the anteroposterior diameter that is less than 3 times the lateral diameter, that left ventricle is bad. So these are all some of the ways in which people assess the left ventricle's adequacy. So this is a banana-like squashed appearance of the left ventricle, again indicating that left ventricle is inadequate. Transposition with ventricular septal defect, VSD can be restrictive VSD or a large VSD. It can be located anywhere in the septum. 30% of them will be in perimembranous location. In perimembranous location in a normal heart will be immediately below the aortic valve. Whereas perimembranous VSD in a TGA will be immediately below the pulmonary valve. So it can also be called as perimembranous subpulmonic VSD. 30% perimembranous subpulmonic, 30% muscular, 30% malaligned. Malaligned means either anterior deviation, either posterior deviation, some coronal septal deviation, straddling of the tricuspid valve, straddling of the mitral, some malalignment in 30%. About 5% will have an inlet VSD without any malalignment, and 55% will be subarterial. That means it will be subaortic. VSD is present in almost 50% of the patients. Hemodynamics of a VSD. Short while ago we were discussing the hemodynamics of an ASD. In systole, RV pumps into high systemic vascular resistance, LV pumps into low pulmonary vascular resistance. So blood will flow from RV to LV in systole. Just like how we will have a left-right shunt in any VSD, in transposition there will be right to left shunt, RV to LV. In diastole, what happens? This increased pulmonary venous return that comes back in the LA and LV will fill the LV better, and so the blood flows from LV to RV. So RV to LV in systole and LV to RV in diastole. VSDs can be in various locations. This is a muscular ventricular septal defect, LV giving the pulmonary artery and RV giving the aorta. Now, PDA, the hemodynamics, the systemic vascular resistance is always higher than the PVR. So blood will only flow from aorta to PA. Rarely, if the PVR exceeds the SVR, then blood will flow from pulmonary artery to aorta and causing reversed differential cyanosis. So TGA with restrictive PDA, so continuous aorta to pulmonary flows. TGA with a large PDA, there can be bidirectional flow. So this is a large PDA, almost as big as the aorta. So there is a bidirectional flow. You'll find blood is flowing from PA to aorta in systole and aorta to PA in systole. So this is the characteristic Doppler pattern of TGA with PDA. Aorta to PA to aorta in systole and aorta to PA in diastole. When will prostaglandin work in patients with transposition? If there is a combination of PDA with a moderate sized PFO, blood will flow from the aorta to PA at the ductal level. This increases the pulmonary venous return, and the increased pulmonary venous return causes the PFO to flow from LA to RA. So this is the best intercirculatory mixing and improves the saturation maximally. So TGA the prostaglandin will work in a patient who is having a moderate sized PFO. But if suppose the IAS is intact or the PFO is too tiny, increasing the pulmonary venous return will result in high left atrial pressure and it will worsen the respiratory distress of the child. So these children will become moribund with respiratory distress, tachypnea, severe pulmonary venous hypertension if they have intact atrial septum. These babies will need an emergency septostomy. Coming to bronchopulmonary collaterals, PDA and bronchopulmonary collaterals are the extracardiac mixing. So bronchopulmonary collaterals. Bronchopulmonary collateral basically offer an additional source of QP. Since PA sampling, when we are doing the catheterization, PA sampling is often done in the proximal PA. The proximal PA saturation will be very high, and so the PV minus PA difference will be very low. So Fick principle falsely increases the QP. The true QP will be known only if we sample the pulmonary artery in the precapillary bed after the bronchopulmonary collaterals enter the lungs, which is very difficult to enter by catheters. And so we will not be able to assess the QP properly in a patient who is having transposition of great arteries, since we are sampling the proximal PA. Since these bronchopulmonary collaterals keep feeding the precapillary level with high amounts of blood flows, I already told that it causes an increased PVR by causing some endothelial shear stress. The additional problem is this will also lead to underperfusion of the body in cardiopulmonary bypass. When you are doing the arterial switch or senning operation, all these aortopulmonary collaterals will steal the blood and so lead to underperfusion of the tissues. And postoperatively, sometimes you will have gross heart failure. A patient who underwent arterial switch operation and the patient is very sick. So finally you enter, you can see the catheters going and putting coils here. This is a micro catheter that is going in, and these are all micro coils. So the small collaterals can create postoperative persistent heart failure. Coronary patterns in transposition are very important because for arterial switch you need to transfer the coronary. It's classical that around 66% or 2/3 of the patient will have what is called as a normal coronary. In a normal coronary, the left-sided sinus will give the left coronary artery and the right-sided sinus will give the right coronary artery. So imagine that you are the surgeon and you are sitting in the pulmonary artery. Your right hand side will be on the left-facing sinus and your left hand will be on the right-facing sinus. So the right hand will be called as sinus 1, the left hand will be called sinus 2. So the sinus 1 gives the left-sided vessels, sinus 2 gives the right-sided vessels. Circumflex from RCA is the next common abnormality seen in about 16% of the patients. So this here around 66% and here about 16%, put together more than 80% of the patients will have benign coronary, not much of abnormalities. All these are abnormal. Single left coronary, single right coronary, inverted RCA and circumflex, intramural coronary, all these are abnormal. It's very important to notice these abnormal coronaries because they increase the mortality during arterial switch operation. So the coronaries that is important for us are single RCA, single LCA, inverted coronaries and intramural coronaries. So we need to understand what is this. The normal coronary artery is the sinus 2 is giving off the right coronary artery and the sinus 1 is giving off the left coronary artery. But in this patient, if you see, the sinus 2 is giving off right coronary artery and the circumflex which is coursing behind the pulmonary artery. So the circumflex and RC are arising together and the LAD is arising from sinus 1. So this 1L2 RCX is the commonest abnormality seen in about 16% of the patients, and this is relatively benign, not of much of concern. So what are the coronaries for which we are concerned? This is single right coronary artery. This is of concern for us. So the coronary artery is arising here, the right is given up here, left is given up here. So this is of concern, a single right coronary. This is another example of a single right coronary. The coronary is given from the right. This is the right coronary artery. It is giving the left coronary artery. The left continues here. It continues as the anterior descending and the circumflex. So this is single right coronary artery. This particular view of taking the angiogram is called apicaudal projection. This is also called as laid back angiogram. The reason why this picture is important is this is almost the equivalent of what you get of the echocardiogram. So echocardiographic images and this particular image will match. This is single left coronary artery. So when there is a single left coronary artery, from the left facing sinus you are finding this is the right, this is the left. So the entire coronary artery is arising from the left facing sinus. So this is single left coronary artery. What is inverted coronary artery? Normally you are supposed to have right coronary artery from the right facing sinus and left coronary artery from the left facing sinus. Imagine that the right coronary artery is arising from the left side and left is arising from the right, then it's called inverted coronary. So this is an example of an inverted coronary. So, and I would like to show this picture also. This is the classical way in which a laid back angiogram has to be done. You pass a balloon flotation catheter, enter into the ascending aorta on an epicaudal projection and start injection. And as you start injection, inflate the balloon. You don't inflate initially, because if you start inflating initially, you will occlude the aorta and the patient will be hypotensive. So you have to start inflating. You have to start inflating only when you are ready with the injection. So now you see the balloon is not inflated. First the balloon gets inflated. Now you have occluded the aorta. Now we are injecting into the coronary, into the aortic root. Since you have trapped the contrast in the ascending aorta, the contrast fills very well and the blood does not move. The blood just stays in the ascending aorta. And now let us see when the coronaries are filling, how I'll freeze it when the coronaries are filling and show you how to identify what is a coronary. It is going back. So now I will drag it. This is the anterior sinus 1. This is the posterior sinus 2. The sinus 1 is giving off both the right coronary artery and the LAD, and the sinus 2 gives off the circumflex. So this is inverted because the right is arising from the sinus 1 and left is continuing from the sinus 2. So this is inverted. So this inverted coronary is a high risk for arterial switch operation. Okay, and this is the way in which a classical laid back aortogram has to be done. Now this is intramural coronary. What is intramural coronary? Intramural coronary means a coronary that shares the wall with the aorta. So now let me freeze this coronary. Now you can appreciate that this is the sinus 1 and sinus 2. From the sinus 2, the right coronary is normally arising, but the left coronary artery is arising here and it courses all the way towards the left, and in this entire wall it is sharing the wall of the aorta. So what is the definition of an intramural coronary on echocardiography? The intramural coronary should arise from the contralateral sinus. It should cross over the commissural area. It should be between the aorta and the pulmonary artery, and the wall of the coronary artery should be shared with the wall of the aorta. So an intramural coronary's definition on echocardiography are: LCA should arise from the right sinus, or RCA should arise from the left sinus, so contralateral sinus. It should cross the commissural area. This is the commissural, so it should cross the commissural area. It should share the wall here. There should be a common wall between the coronary artery and the aorta, and it should be between the aorta and the pulmonary artery. So this is the definition of intramural coronary artery. And how this is the intramural coronary artery. So how will you this is the same laid back angiogram. You see now this is the balloon that is being inflated. I'll freeze it now. It's a beautiful picture. Now see what is happening here. This is the aorta. Here is the pulmonary artery because it is the D-mal post aorta. See the right coronary artery normally arising. Left is also arising from there, and it courses touching the wall of the aorta. So this is that wall, common wall that is shared between the aorta and the pulmonary artery, aorta and the coronary artery, and the coronary artery exits here. So this is the classical intramural coronary artery. So these coronary arteries, the significance is you need to identify them because they add to the risk of the surgery. Left ventricular outflow tract obstruction is common. It occurs in about 25% of the patients. In 20% of patients with intact ventricular septal defect, and 30% of the patients with VSD will have ventricular septal defect. Obstruction can be at subvalvular or valvular level. In TGA with intact ventricular septum, LVOT obstruction is often dynamic. It can either be from the systolic anterior motion of the anterior mitral leaflet, or it can be caused by leftward bulging of the basal interventricular septum due to the lower pressure of LV. This is a patient who is having a TGA with a pulmonary stenosis with a VSD. The pulmonary valve is small. The subpulmonary area is also small. So this is a annular pulmonary stenosis, valvular pulmonary stenosis with an infundibulum pulmonary stenosis. And this is isolated valvular pulmonary stenosis. This is left ventricle giving pulmonary artery, isolated valvular pulmonary stenosis, doming pulmonary valve. And this is an isolated valvular pulmonary stenosis. And in this patient, this is a posterior malalignment of the conal septum. The conal septum is dipping posteriorly. So this is a malaligned VSD causing pulmonary stenosis. So this is, in this patient, there is a ventricular septal defect. You can see some flowery structure from the right ventricle protruding into the subpulmonic tract. So what is this flowery structure? This is an accessory right AV valve tissue, and that is protruding. So that can cause some amount of subpulmonary stenosis. And this is a dynamic LVOT obstruction. Intact ventricular septum, RV is high pressure, LV is low pressure. So the septum bows into the left ventricle, resulting in dynamic subvalvular obstruction. So again, for exam purpose, what are the reasons of transposition to have left ventricular outflow tract obstruction? In the presence of ventricular septal defect, it can be due to infundibular muscle hypertrophy. That is something like subvalvular muscular PS. There can be posterior deviation of the conal septum. There can be accessory right-sided AV valve tissue. The tricuspid valve tissue can protrude into the LVOT. Left-sided AV valve tissue may have an abnormal attachment to the margins of the interventricular septum and cause LVOT obstruction. Normally, left AV valve should not have a septal attachment. You know, mitral valve is septophobic. But if it is an abnormal mitral valve with abnormal attachment of its caudal apparatus to the crest of the interventricular septum in the VSD, then that can produce LVOT obstruction. Membranous septal aneurysmal bulge may be present. If you have a perimembranous ventricular septal defect, and that forms a membranous septal aneurysm, that aneurysm can bulge into the left ventricular outflow tract and cause a LVOT obstruction. In the presence of intact ventricular septum, it can be dynamic narrowing due to SAM. It can be a septal bulge due to low LVSP. It can be a lot of hypertrophied muscle on the left side caused by hypertrophied muscles of molar. It's a named muscle on the left side. It can be due to valvular pulmonary stenosis. It can be due to annular TS. It can be due to subpulmonary membrane. It can be due to fibromuscular ridge. It can be a diffuse long left ventricular outflow tract tunnel. RVOT obstruction is almost always in the form of coarctation. Very rarely there can be subaortic stenosis. This is mild arch narrowing, and sometimes the arch narrowing can be terrible. This is a tight post-subclavian coarctation. So varying degrees of right ventricular outflow tract obstruction can occur. What happens to the right ventricle? Right ventricle is very important because it is a systemic ventricle in the transposition. So right ventricle sometimes can be hypoplastic, sometimes can be dysfunctional. In a normal heart, tricuspid annulus is always bigger than the mitral annulus. But in transposition, tricuspid annulus may be equal or sometimes smaller than the mitral annulus. We need to remember that. In normal heart, if you are doing a normal echocardiogram for a, say, a 10-year-old child, the tricuspid annulus will be larger. But in a transposition, tricuspid annulus is smaller. Hypoplasia may be present, and if there is a hypoplasia of the tricuspid valve, then it can be associated with arch obstruction. So this is the right ventricle. You can see that it's marginally smaller, and the tricuspid valve is smaller than the mitral valve. RV can sometimes be dysfunctional because it is now facing the systemic circulation. So RV can be dysfunctional. When there is a RV dysfunction, you will have systemic venous congestion. Left juxtaposition of the atrial appendage is a peculiarity that is seen in transposition quite often, where right atrial appendage protrudes onto the left side. Importance of knowing this particular condition: when you are doing a balloon atrial septostomy, you are supposed to cross from the RA into the LA and do a septostomy. Sometimes if you put in your balloon into the right atrial appendage, inflate the muscle, inflate the balloon and pull it back, you will be avulsing the wall of the right atrial appendage and creating cardiac tamponade. And so you need to understand that where you are entering is LA and not a juxtaposed atrial appendage. It's important to know that. Bronchopulmonary collaterals can be identified sometimes on echocardiogram itself. This is the descending thoracic aorta with lot of collaterals that you see. Depends on prostaglandin. So this is how a balloon septostomy is being done. You are seeing the LA, RA, and this is the balloon that is being inflated and suddenly pulled back, and when you are pulling it back, you are getting a tear in the atrial septum. And post balloon septostomy, you will have a torn septum with good intercirculatory mixing. When will you do BAS? When the baby is very hypoxic, critically hypoxic. When the baby is dependent continuously on prostaglandin, that you are not able to wean away the prostaglandin. You need some time to settle neonatal issues. There is a baby who is born to you but with malignant hyperbilirubinemia. You have to do some exchange transfusions for another 15 days, 10 days to get the bilirubin down. The child is having moribund sepsis. You need to give antibiotic for 7 days. The child is having an anal atresia. There is no meconium that's passed. You need to do first a colostomy and then only you can do the arterial. So you need time. Then you do balloon atrial septostomy. You are not able to do any switch in your hospital. You have to transfer the patient, say from Bangalore to Hyderabad to do this operation. Then you have to you do a balloon septostomy and then transfer, because the child needs to be stable. Transposition with ventricular septal defect, you will have reasonably good saturations, but the problem is high left atrial pressures can result in severe respiratory distress due to PVH. So to relieve the dyspnea, you may have to do a balloon septostomy, even though saturations are good. You have a patient who is having an intramural coronary artery and not suitable for arterial switch, or you want to plan an elective sendings later, then you do a balloon septostomy. So these are all some of the indications for doing a balloon septostomy. What is the endpoint of septostomy? The saturation should be more than 80%. The PO2 should increase by 10 millimeters of mercury, and the tear should be more than 6 millimeters in anatomical size. Can balloon atrial septostomy fail? Yes, it can fail. There are some people who are called non-mixers. Irrespective of however big a septostomy you make, the blood will not mix. Left atrial blood will continue to go into mitral valve, right atrial blood will continue to go into tricuspid valve, they will not mix. So these are called non-mixers. So they will not mix. People who are having high pulmonary vascular resistance will continue to have hypoxia. Some patients will have elastic septum. Full balloon will come out, but it will entirely recoil back, and there won't be any hole that is seen after the septostomy. Any ventricular outflow tract obstruction, any ventricular hypoplasia, balloon atrial septostomy may not work as effectively. In such cases, restart prostaglandin. What are the alternatives that are available for balloon septostomy? Sometimes you can do static balloon dilatation, mostly needed in grown-up patients, not often needed in neonates. The other methods like Park blade, septostomy, atrial stenting are all almost never done because they are more morbid procedures. Arterial switch is the definitive treatment. Main pulmonary artery and ascending aorta is transected and switch coronary buttons are transferred. Important surgical considerations. We need to identify the preparedness of the left ventricle, whether you need retraining or not, presence and location of VSD, PDA, arch obstruction, coronary anatomy. What is LV retraining? LV retraining is used in patients who are having inadequate LV. That means LV has regressed already. What is the principle? You have to induce a volume overload and pressure overload to the left ventricle so that the left ventricle hypertrophies sufficiently to maintain your systemic circulation. What are the methods of doing that? You can do pulmonary artery banding. You can do BT shunt. You can do combination. Either pulmonary artery banding alone or BT shunt alone or pulmonary artery banding plus BT shunt. PDA stenting is also another retraining strategy. PDA retraining is, this is the PDA stent, and you have crossed over from the aorta through the ductus into the pulmonary artery, and you have stented the PDA. So you are driving the blood from the aorta into the pulmonary artery. This increase in the pulmonary blood flow will come back through the pulmonary vein back into the LA, and that LA blood will go into the left ventricle. This left ventricle now will get volume overloaded. So you are giving a volume overload related hypertrophy of the left ventricle. This aorta now is pumping the blood through the PDA stent into the PA. So the PA increases its pressure. You induce pulmonary hypertension. So pulmonary hypertension induces pressure overload on the left ventricle. So you are inducing a combination of volume overload and pressure overload. This is a transposition, ductal stent. Blood is going from the aorta into the pulmonary artery, causing high pulmonary artery pressure, so pressure overload, increased venous return causing LA, LV being filled, so volume overload. You see that this is the right ventricle, this is the left ventricle, LV is looking really filled. So what is it due to? It is due to ductal stenting induced combination of pressure and volume overload. So this is what is the effect of PDA stenting. ductal stenting retrains left ventricle. This is the ductal stent. Aorta, PA, ductal stent. The same thing can be done by doing a pulmonary artery banding also. You see, this is the PA banding. You are able to see an umbilical tape here. This is the PA banding. So the pulmonary artery is now squeezing against the PA band and so increases its proximal PA pressures and increases the left ventricular pressure. And this is the PA banding, and you are able to see the gradient across the PA band. So what is the role of PA banding in a transposition? When will you do a PA banding in a transposition? Rapid two-stage arterial switch, that means you do a PA banding plus or minus BT-shunt, and within about 1 week or 2 weeks you take up the patient for arterial switch operation. This is called rapid two-stage arterial switch, done in the same admission. Delayed two-stage arterial switch, that means you do the PA banding, discharge the patient, get back the patient after 6 months, and then do the arterial switch. Single stage ASO, that means you do it all in a single stage. So you go, put a band, wait for a few minutes, look at the pressures, look at the LV function, look at the mitral regurgitation on transesophageal echo. The patient is tolerating the band with increased LV pressures, go ahead and do the switch. So these are some of the indications for doing pulmonary artery banding as a process of retraining the ventricle. A TGA with VSD who is unfit for an immediate arterial switch operation due to any morbidity, multiple Swiss cheese ventricular septal defect, intramural coronary arteries, you are not able to tackle the anatomy. So you do a PA banding temporarily and then get back the child to an expert surgeon in some other center or whoever can do it later. Arterial switch operation has become the standard of care now. The follow-up after arterial switch operation, you have to look at LVOT and RVOT obstruction. Very common to have supravalvular pulmonary stenosis. Branch pulmonary artery narrowing, neo-aortic regurgitation and neo-pulmonary regurgitation. Aortic regurgitation is notorious. Aortic root dilatation. Residual ventricular septal defects. Coronary issues. Some of these coronaries may get occluded. LV function. LV dysfunction is often due to coronary compromise. This is an example of a supravalvular pulmonary stenosis. RV. You are injecting the blood and there is a discrete supravalvular pulmonary stenosis. The place where you have anastomosed, you have a severe stenosis and that has been relieved now with a supravalvular PA stenting. So whenever you are having a discrete supravalvular pulmonary stenosis in a post-switch patient, you sometimes may intervene and get it corrected. Senning operation is done in late presenters. Patient is already presenting too late and the LV is completely regressed. LV cannot be trained. Then you do senning operation. The concept is here physiological correction. That means pulmonary veins are baffled to tricuspid valve, systemic veins are baffled to mitral valve. Since you are going to listen about all these surgeries, I am not going into the technical aspects of these surgeries. I am sure in another 1 week's time a surgeon is going to talk to you about what are these surgeries. But we need to understand how to assess a patient after these surgeries. So this is the pulmonary venous blood that is coming back to the right atrium. This is the pulmonary venous baffle. So this is the pulmonary venous baffle. All the pulmonary venous blood enters into the right atrium and right ventricle through this baffle. Follow up after sending surgery, you can either have a baffle leak or baffle obstruction. RV dysfunction and tricuspid regurgitation may happen. These are late complications. How to recognize baffle leaks and baffle obstructions? This is an example of a baffle leak. You are injecting into the superior vena cava pathway, and if you look here, this is a catheter that goes down from the inferior vena cava into the superior vena cava. So this is the superior vena cava, and as we are injecting, the superior and inferior vena cava should fill the posteriorly placed left ventricle and enter only into the pulmonary artery. But you see now here what is happening. There is a large leak of the blood into the anterior right ventricle and another leak here into the anterior structure. So this is a shunt from the systemic venous pathway into the pulmonary pathway, into the aorta. So what will happen? This patient will have desaturation, hypoxia. So you see here, these are the two large baffle leaks. So one superior and one inferior. So senning baffle leak will manifest with hypoxia, and this is the senning baffle leak. The lower one has been closed, the upper one has been closed. I will again freeze it when the contrast is filling. Now you see, there was a baffle leak here which is closed by this device. There was a baffle leak here that was closed by this device. So this is senning baffle leak device closure. Postoperative sendings may have baffle obstruction. So this is a pulmonary venous pathway obstruction. You see a tight obstruction with a gradient. So how will you relieve it? You may have to do a transeptal puncture, enter into the pulmonary venous pathway and do some balloon dilatations and get it opened out. So this is pulmonary venous baffle obstructions, again treated interventionally. So to summarize, transposition is very common cyanotic heart disease. We need to understand the hemodynamics. If you are asked a question about what is QAS, QP, QES, QEP, anatomic shunt, physiologic shunt, you should be able to tell in very clear terms. You need to understand hemodynamics of transposition. Echocardiogram is very important for finding out all the associations of a TGA. There will be something that you want to understand in the atrial septum, something that you want to understand in the ventricular septum, something that you want to understand about the left ventricular adequacy, coronary arteries, outflow tract obstructions. I listed out various reasons for outflow tract obstructions, listed out various locations of VSD. So every point you need to look at in the echocardiogram. You all should be able to tell what is the indication for septostomy, what is the indication for PA band, what is the indication for PDA stent. Of course, arterial switch operations and sending operation will be the definitive treatment. And if you have a patient with arterial switch operation or sending, what are the sequelae and how will you manage with the sequelae? So this is in short a summary about transposition of great arteries. Any of you having questions here?
More than 1.5 is prepared.
1.5 is too small. 2.5 gram per ml is what is needed. If you do a volume assessment of the left ventricle in a classical transposition, very often you will have a volume something like 4 ml, 3 ml. Very small, LV will be very small. So if you put a mass to volume ratio in such patients, the mass to volume ratio will often be more than 3-4 grams. You need to have more than 2.5 grams per ml. More than 3 is better. Very often it is very subjective. Very often the assessment is just eyeballing. And people don't look at all these numbers very critically. There is a group of surgeons who will not worry about any sort of left ventricle. Go ahead and do a switch and put the patient on ECMO and support the left ventricle for 2 to 3 days. Allow the left ventricle to come out. There are a group of surgeons who will be concentrating on all these aspects, because in centers where you are not having good setup for ECMO, prolonged ventilatory supports, it is important that you should have select a good patient. Any patient, whoever is having a saturation of more than say 80%, is having fairly adequate amount of pulmonary blood flow and reasonably operable PVR, so you probably can go ahead. Patient is having less than 80% saturation in the presence of large ventricular septal defect, and the child is say less than 2 months. Assumption is that 1/3 of them may have high PVR, 2/3 of them may not have high PVR. Sorry, 20% of them will have high PVR, 80% may not have high PVR. So go ahead and operate. Child is more than 1 year, very bright possibility high pulmonary vascular resistance will be there. So be very cautious. You doing a cardiac catheterization is not going to be of great help, because almost you will not be able to calculate the QP and all very accurately. So in such patients, if you are forced to take up for an arterial switch, one of the options will be to leave behind a fenestration, a decent fenestration in the ventricular septal defect patch, and go ahead and do an arterial switch. It will be more like a palliative arterial switch, because the large VSD fenestration that you are leaving behind will result in persistence of pulmonary hypertension, but the only thing, the oxygenation will slightly improve. These patients, transpositions with very large ventricular septal defect who are more than 1 year of age and who have already established pulmonary vascular resistance, or very often they don't have too long good prognosis. So that is one of the bad things. I'm seeing only one question, Savita. Why mixing is best in an ASD? Actually, mixing occurs both at ASD and ventricular septal defect. Ventricular septal defect will be at the cost of significant elevation of the pulmonary artery pressure, thereby harming the hemodynamics. ASD is significant improvement in the oxygenation without affecting too much the pulmonary vascular system. So on that count, ASD is better. It doesn't mean a patient with a large ventricular septal will also have a good mixing, will also have a good amount of saturations. So in fact, a transposition with a large VSD will have fairly well preserved oxygen saturation. The mixing is best in ASD because it does not affect the hemodynamics too much. It does not cause an elevation of the pulmonary vascular system, does not make the patient become inoperable to this. Both if you have a large atrial septal defect and a large ventricular septal defect, the amount of admixture, the amount of QEP crossing over will be almost similar, and you will have similar saturations. In terms of maintaining preventing critical hypoxia, both are equally effective. But VSD is notorious in provoking high pulmonary vascular resistance and making the patient become inoperable.
Okay. Thank you, doctor. Okay, there's one more question.
What is the cause of bronchopulmonary collapse? It's basically a developmental problem. No? Whenever you are having no specific reason can be attributed why there is a bronchopulmonary collapse. Your body is now tuned for pulmonary arterial blood having high amounts of oxygen saturation. So high amounts of oxygen saturation is going back again and again into the lungs and not effectively contributing to improving the oxygen saturation at all. So the tiny nutritive bronchial arteries, they become more and more prominent, and the amount of blood that is going through these nutritive bronchial arteries become very intense. Cause of why the bronchopulmonary collaterals appear cannot be told because it just develops. But I was concentrating more on what is the harm that is caused to by bronchopulmonary.
Thank you, doctor.
Thank you very much.